To promote healing, you must provide treatment that's appropriate for the patient's pressure ulcer. Yet the staggering number of wound care products has made even the simple act of choosing a dressing more complex than ever before. Fortunately, you can make sound choices with ease if you consider your assessment findings and focus on the 3 basics of wound treatment: pressure relief or reduction, local wound treatment, and proper nutrition. So let's start with techniques to relieve pressure. Remember to follow your facility's policies when selecting a support surface for pressure relief or reduction. If your patient can't reposition himself independently in bed, arrange for a special support surface, such as a replacement mattress, foam or static air overlay, dynamic air mattress, low air loss replacement mattress, gel replacement mattress, low air loss bed, or high air loss bed. If the patient needs help to reposition himself in a chair or wheelchair, assist in obtaining an appropriate cushion, such as a foam, gel, or air-filled cushion, or one that suspends the ischial tuberosities and sacrum. Select the cushion that fits the chair and best meets the patient's needs. For example, if the patient ambulates occasionally and can shift his weight and lift independently, try a simple air cushion or foam or gel pad. But if the patient has a spinal cord injury, multiple sclerosis, or similar disorder, consult a knowledgeable physical therapist who can properly fit a cushion to a specialty wheelchair. Because insurance coverage and reimbursements may dictate the products available for pressure relief, select from the available products and then monitor and document the pressure ulcer's progress. If it improves, the product is appropriate. If it worsens or if more ulcers form, evaluate the situation by asking yourself these questions. Has the turning schedule been followed? Has the patient's medical condition improved or stayed the same? Is the support surface inflated and functioning properly? Check it by hand to assess its inflation. If you answer yes to these questions, then try upgrading the support surface. And be sure to document your evaluation, recommendations, and outcomes. If you need help with the evaluation, consult or reconsult a certified wound care specialist and other team members as appropriate. After the specialist completes an evaluation, collaborate with her to identify treatments that can meet your patient's needs. The next part of the treatment is local wound care, which includes cleansing, debridement, and dressing. For cleansing, you may use normal saline or a commercial wound cleanser that does not contain harmful chemicals. In the home, commercial cleanser may offer greater convenience, cost-effectiveness, and compliance with infection control guidelines. In long-term care, you may want to keep a bottle of normal saline on the treatment cart for treating more than one resident. To prevent cross-contamination, take just the amount of solution you need into the resident's room. Do not use an antiseptic agent such as povidone iodine, hydrogen peroxide, or acetic acid to cleanse a pressure ulcer, because these agents are cytotoxic. They inhibit ulcer healing. After choosing a cleanser, select the method of cleansing. You may wipe gently with a moist gauze, or you may use wound irrigation, particularly if the wound has sinus tracts or extensive undermining. Remember to irrigate gently, using a pressure of 4 to 15 pounds per square inch. According to the AHCPR guidelines, this safe, effective pressure can be achieved with a piston syringe, saline squeeze bottle, or a water pick set on low. Consider whirlpool treatment to cleanse pressure ulcers that contain thick exudate, slough, or necrotic tissue. Discontinue this treatment once the wound base develops granulation tissue. Next, debride any necrotic tissue using the method that's most appropriate for the patient's condition, goals, and setting. Sharp debridement involves the use of a scalpel, scissors, or another sharp instrument, and forceps. It should only be performed by a credentialed professional and can be used to manage wounds with advancing cellulitis or sepsis, or to access the wound base rapidly. When sharp debridement is not indicated, use mechanical, enzymatic, or autolytic debridement. Mechanical debridement may be achieved through hydrotherapy or wound irrigation. These techniques are used to soften and remove eschar and debris. Mechanical debridement can also be done with a wet-to-dry dressing, which adheres to necrotic tissue so that it can be pulled off with the dressing. However, this non-selective procedure can cause pain and can harm granulation tissue. Enzymatic debridement calls for the use of topical debridement agents. To facilitate autolytic debridement, tissue may be rehydrated with viscous hydrogel. Then, during autolytic debridement, a synthetic, moisture-retentive dressing is applied over a pressure ulcer, which allows the enzymes in its fluid to digest the necrotic tissue. Continue the local wound care by applying an appropriate dressing, using clean technique or other technique required by your facility. Hundreds of dressings are available. Some are designed to absorb exudate, others to promote granulation tissue growth and epithelialization. So base your selection on the patient's needs, setting, financial constraints, and your preference. Finally, address the patient's nutrition. By assessing his nutritional status and managing his diet, you can help him get the nutrients he needs to promote healing. If the patient is at risk for pressure ulcers, perform a nutritional assessment during admission, at least once every 3 months thereafter, and whenever the patient's condition changes significantly. Ideally, the patient should eat a balanced diet and should weigh more than 80% of his ideal body weight. Any weight loss should not exceed 5% in 1 month, 7.5% in 3 months, or 10% in 6 months. Also, the patient's albumin level should be greater than or equal to 3.5 grams per deciliter, his serum transferrin level greater than 180 milligrams per deciliter, and his total lymphocyte count greater than or equal to 1,800 per cubic millimeter. For any patient with a pressure ulcer, encourage him to eat a balanced, high-protein diet and drink adequate fluids. For a malnourished patient with a pressure ulcer, suggest supplementation with vitamin C, zinc, and other nutrients that support wound healing. If that's not possible, consider tube feeding to achieve a positive nitrogen balance. Remember to document the patient's nutritional assessment and treatment in your notes. For details on dressings and nutrition, consult the booklet that accompanies this video. When discharging a patient with a pressure ulcer, follow these suggestions. Refer her to a home care agency with a certified wound care specialist on staff. Send the patient's records home with her or directly to the agency. Give her 2 days' worth of dressings to ensure that treatment continues until home supplies arrive. And document your discharge instructions. Thorough documentation of discharge instructions is particularly important. Be sure to document that you provided discharge instructions and that the patient and family member indicated that they could perform them. Although you can't guarantee compliance, you should make every effort to promote pressure ulcer management after discharge. As you've just seen, pressure ulcer care presents many challenges. To help prepare you to meet these challenges, this video reviewed pressure ulcer risk assessment, prevention, staging, healing, assessment, and treatment. It also provided tips to help you reduce your exposure to legal liability. Armed with this practical knowledge of the clinical management of pressure ulcers and their legal considerations, you can successfully care for your patient's ulcers with confidence.